Postpartum coping. We talked in the postpartum PowerPoint bubble he and assessing our patients. The last E of the bubble he is emotional status. And this is a very important part of your postpartum assessment with postpartum depression and mood disorders, such a huge part of today. Because it's such a huge part, we have lots of screening tools. And what we're screening for is to see how well our patients are coping with parenthood, with being a mother, with all the changing hormones and all that's going on in the postpartum period. We know that our population is very vulnerable for depression and other mood disorders. And so we do a screening tool during pregnancy. And we also do one in the postpartum period, and the doctors will continue to monitor those patients as well. What we're doing in those screening tools is we're looking for risk factors for mood disorders. So any patient coming into the pregnancy with the risk factors, such as a history of mood disorders, such as anxiety, panic disorder, depression, bipolar, and the list goes on. If they check mark yes to any of those, the flag is risen. It's the red flag saying these people we have to watch very closely because they are more prone for problems in coping in the postpartum period. So the objective is to prioritize signs of potential complications in the postpartum woman. And we're going to talk a lot about postpartum blues and postpartum depression, and then some of the other mood disorders that occur in the postpartum period. What we know is that in postpartum, there is so much going on. They spent 40 weeks gestation. They spent 40 weeks pregnant. Their bodies have been adapting to pregnancy and preparing for the big birthday. They've had all kinds of hormonal changes in that time, preparing for birth and to actually grow the fetus inside them. And then all of a sudden they deliver, and the placenta is delivered, and all of a sudden the estrogen levels and the progesterone levels drop, and we have an increase in prolactin and oxytocin, and all the hormones change. In addition to all the hormonal changes, we have a woman that is now a mother, and many times it's the first time, and they're dealing with breastfeeding. They're dealing with the changes in their body and having another little life there. And so our patients, it's a time of vulnerability. Okay, so they're already prone to maybe having a harder time to cope with all the changes. It's disruptive to the family life. And it's at this time that mood and anxiety disorders are likely to reoccur if they've had them in the past, or actually appear if there's a history of them, or actually appear for the first time. What we do know is the failure to address any of these mood disorders may result in tragic consequences. And so it's really important to keep an eye on it and to look for those patients that are more vulnerable to mood disorders and to be available to give them resources to help them during this time. Many times we have women who have a family history and they have no idea that they are prone for depression or anxiety or bipolar. And sometimes during this vulnerable period, it may happen. And even if you have no history or whatever, it's still this time is very vulnerable. For instance, it's hard enough to cope with a postpartum in the postpartum period with having a baby and all the hormonal changes and changes occurring within the body. And sometimes the labor didn't go as planned, or maybe there was a problem with the baby. Those are hard enough things to cope with. So a woman is very vulnerable. But if anything happens at this time, maybe they normally would be able to handle it. But during this time, there's just so much going on that they have a harder time. For instance, if I've had patients come in and they've just lost their mother, and it's so tragic that it would be hard enough to deal with that loss even on a normal period of time. But couple that with having the baby and all the changes that go with that, it doesn't take much for them to kind of go and develop some type of go into depression or whatever. So they're very vulnerable. In addition to that, I mean, I've seen patients have, lost their job, have socioeconomic problems. Maybe the father of the baby left them at the last minute. These are hard enough things to cope on a day-to-day basis, but add that on to the postpartum period, and it really makes the situation a lot worse. So normally, I mean, patients are pretty, strong and everything else, but when they're very vulnerable, like in this postpartum period, it just doesn't take much to go off into the other way. So we keep an eye on our patients. We have screening tools to see who's at higher risk. We constantly asking them. When a patient delivers, we're constantly looking to see how well they're coping with it. Are they talking to the baby? Are they holding the baby? Are they interested in caring for their baby? There are some people that say, no, you can do it, you can do it, you can do it. And they have no desire to do anything with their baby. That's a warning sign. Most parents are eager to learn and to hold and to learn how to care for their babies. So there's so many things that we're looking at during this whole time. It's hard to believe, but yes, there are babies that are born where the parents are not attached. They don't really want to hold. They don't call the baby by name. And it's very sad, but we have to be in tune to look for that and address that and to get the help needed for that family to cope with it. If we look at the support system as well, again, the importance of the support system is unexplainable here. The support system will help. So if there's a partner that's actively involved in helping the mom and supporting the mom, then that person has a support system that may help them cope through this period. Family members, parents, grandparents, any type of support system. As they say, sometimes it takes a village to raise a child. That is called a good support system for an individual to lean on. So we always look at the support system that the pregnant woman comes in with, and is it a good support system? If they come alone, that's kind of like a red flag. Who is their support? Because this is when they need support the most. This is when they need the village to help them raise this child. We also have to assess how they have their past coping mechanisms. How do they handle stress? And have they dealt with stress before? Have they dealt with a loss before in their past? And were there coping mechanisms to get them through that time? For instance, if they've already experienced some kind of a loss. Some people have come in and their support system is overseas, and that's very difficult for them, and they FaceTime them and try to bring them in, but you can tell that the amount of stress and their ability to cope is decreased with that support system there. So we're looking at all of them. We're also the emotional reactions at birth. Are they talking to the baby? Are they holding the baby? And all these we're looking for signs of how well our patient is coping, because we know they're so vulnerable. Some of the emotional reactions we'll talk about are the baby blues, postpartum depression, postpartum anxiety and panic disorders, postpartum depression with OCD, and postpartum psychosis. I'm going to say that the majority of what we see is the baby blues and the postpartum depression and anxiety and panic disorder. I will say this as far as OCD goes, is that any patient with a history, or maybe they've gotten better, or maybe they have a history, or sometimes this is the time of vulnerability where we'll first see symptoms. But a patient with OCD, and we've seen lots of characters on TV with OCD, and how they have to do extra cleaning, or they're obsessed with certain things. A lot of patients with OCD, one of the biggest clues that we find out is their OCD about their baby. They're really concerned with that the baby's got to be sick or there's something wrong. And they show up repeatedly at the pediatrician's office. So the pediatrician has to be very alert to these mood disorders as well, to be aware that maybe the patient's having a hard time coping and pick up some of these features. The same with anxiety and panic disorders. Sometimes we'll see these patients panicking because they lack the coping abilities, and they think that they're not taking care of the baby, and they end up at the pediatrician's office as well. So there's various places that we have to be alert for these mood disorders. See them at any place. It's really important that the family as well and the system, particularly if there's a history, because the support person could be the one that could get them help. Baby blues. It occurs 50 to 80% of the time. If I say it occurs in 80% of our postpartum patient, then I'm pretty much saying almost everybody's going to have a little bit of the baby blues. What are the baby blues? The baby blues are something like, let's say, well, PMS. We know how a woman is sometimes with PMS. Normally, they can handle the stress of tests and other things, but when they're PMSing, their ability to cope decreases. They are more likely to have mood swings of being really happy and then crying for no reason. And that's kind of the same with the baby blues. 1 minute they could be totally happy on the phone saying, oh my gosh, I got this beautiful baby. And then all of a sudden they're crying and they're irritable and they're telling their partner, to get out. They're, bothering them. And this is just part of the baby blues. Remember, patients come in, they've been laboring, they're exhausted, now they're up with a baby, and a very vulnerable time. They've been sleep deprived or trying to figure it out. So this is a normal, actually, baby blues. It's short-lived. It usually goes away within the first couple of weeks, and the patient is able to cope. So even though they have the baby blues, they're still able to cope, but there's just a whole set of emotions of, 1 minute they're laughing, the next minute they're crying. I don't know why I'm crying, but think of all the hormonal changes. They're tired, they're hungry, all kinds of things are happening. But it is short-lived, and usually 1 minute they're crying and the next minute you can get them to laugh. And so you bring them something that brings them pleasure and they're all happy again. Whereas postpartum depression, the literature says that 10 to 15% of our women end up with postpartum depression. Now, I don't know about you, but I'm pretty, when I look at some statistics, I believe that, 10 to 15, but I also, in this particular instance, think that more than 15% maybe experience postpartum depression. And why I think that more people experience it and then our literature shows is because I think a lot of women are shamed or embarrassed to admit that they've experienced some type of postpartum depression. Because if you think about it, when you have a normal, healthy baby, and then maybe even your next door neighbor, their baby's in the NICU, but if you have a healthy baby or you gave birth to a baby, it's supposed to be a happy time. You're supposed to feel happy and blessed that you've got this beautiful baby. But with postpartum depression, it doesn't matter. You just don't have these feelings. And the difference between postpartum depression and postpartum blues is it lasts a little bit longer. But one of the main things is that when you have postpartum blues, it maybe you're a little bit down, but maybe I'll bring you some foo-foo coffee or some beautiful flowers, and it brings you joy and you smile. Somebody who's really depressed, all those pleasure things that usually bring some pleasure, like maybe a cup of coffee would, if up in the morning before they get up, would bring them pleasure. But with postpartum depression or true depression, all those things that normally bring them pressure, nothing does it. They still feel empty and void inside. Those that are more prone for this depression is anybody with a personal or family history of mood disorder. So again, one of the red flags or one of the most important things that we're looking for in a history is, does the patient have any personal history? Do they have a history of depression or anxiety? Were they ever on medications for that? In addition to that, is there any negative life event that has occurred, such as a loss of a loved one, or maybe lack of support, maybe a divorce just went on, or I've had patients come in and they're looking at Facebook and their father of the baby is with somebody else now, and it's causing major stress on them. Financial difficulties, all these things can play on and put a person into a spiral downhill with postpartum depression. I will say this, and you'll probably learn this in psych as well, that anytime there's a history of depression, we always look to make sure that there's not a physical reason, such as a thyroid disorder, that may be causing some of the depression. Some of you may be familiar with who Brooke Shields is. Some of you may not. Brooke Shields is probably about 60 years old now. She grew up as a child star, same way. She was the same age as Michael Jackson. They grew up as childhood stars together. She was beautiful, actress. She was also a model. She had everything going for her. She then got married and she was ready to start a family, and she had difficulty getting pregnant. And she had difficulty getting pregnant, and then she had one or two losses as well as far as miscarriage goes. And that causes people already, it's very hard for women when they're trying to get pregnant and they have infertility issues or problems maintaining pregnancy. It plays a big toll. And a lot of them end up with in vitro sometimes. But regardless, anybody with in vitro or a history of losses or whatever, these people are sometimes more prone for postpartum depression as well. But regardless, Brooke Shield, actually, she finally got pregnant and maintained her pregnancy. With her status, her beauty, and her everything else that was going on, I'm sure she had a plan when she walked into that hospital. I'm sure they had a beautiful suite, somebody picked out to take care of her, and the best of care readily available for her. She went into labor, and her labor didn't go exactly as she planned. She ended up going for a C-section room, and she wrote a book about her experience, and she talks about being wheeled into the C-section room. And as she's being wheeled there, she's thinking about her childhood and looking out of a window, but she appears very detached from the experience that she's about to go through. She gets into the OR, and it's not exactly as she planned. It's very methodic. It's surgery. They're put on a table. The drape went up, and she gave birth to her baby. We're better about it now, but back then, once the baby was born, we would show the baby to the mom, and then we took mom and dad to the recovery room where we weighed and measured the baby, and dad started to bond with baby while mom finished up the surgery. So her husband and the baby went to the nursery to await her arrival for after they did the repair as far as the C-section goes. What she remembers is that she felt like there was a medical emergency. I can't remember in the book if it was a postpartum hemorrhage or whatever, but they fixed it and they would take her to the recovery room. But the thing that is that she internalized such trauma that she felt she was going to die in that C-section. So when they actually wheeled her into the recovery room, there was her spouse and perhaps maybe her mother or somebody waiting for her. And when you go into the recovery room, as we did back then with the person who just gave delivery, they've got the baby, they've already weighed the baby, and the mom's been isolated for about a half an hour, but she goes into the recovery room and everybody's all, look at the baby, how cute, how beautiful, blah, 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 blah. And she was feeling like she came out of a war zone. And when somebody comes out of a war zone, they're kind of in shock, and all they want is somebody to give them a hug and for them to cry on their shoulder. But all of a sudden she comes and everybody's happy, and she felt like she had to be happy. And that was the beginning of her feelings of inability to cope. And what happened in the postpartum period was that she ended up going in depression, and her husband recognized it. She was able to care for her baby, and she attached to the baby as far as breastfeeding goes, but she had this empty feeling, a void. She found no pleasure in life. Her husband tried to bring her help by bringing some people in to talk to her, and it still didn't ring a bell. It even talks in the book how the husband went to the store once and came back and told her, you know what I saw at the store? I saw a woman who was actually happy with her baby. And it sounds cruel, and in a sense it is, but it kind of woke her up. She ended up going for help, and she was put on medication. When a woman does go, there's like a scale, and it's just like diabetes. Sometimes you need medicine to get better. And so they gave her some medicine, and she actually began to feel better and was doing quite well. But then, just like a lot of people that have mood disorders, when she began feeling good, she stopped the medication and spiraled down again. And she ended up getting better after that. What's unique about her is that her experiences back then, she's about 60 now, so that's maybe, 30 years ago? Maybe not even 30 years ago, this happened. And nobody talked about postpartum depression. In fact, I don't even remember a discussion when I was in nursing school about postpartum depression. It was very hush-hush. Nobody even realized that it was actually a thing. And so she came out and she was very public about it, and she wrote a book, Down Came the Rain, that talked about her journey through the postpartum depression. And she was such a beloved person, and that when people saw that and they read that, a lot of women realized that's what they had gone through. And all of a sudden the door was open for people to talk about it. And even though still it remains for some people difficult, but she provided millions of women with an inspiring example of recovery and reality. And now, just because she spoke about her postpartum depression, and now when you look up literature or whatever, there's lots of books and a lot of women who we understand its significance. In every hospital, all these big hospitals that we're surrounded with, they all have support groups for women who are going through this so that they don't feel so alone, and it helps them on their road to recovery. Again, what's the symptoms of postpartum depression versus the blues? The blues are short-lived. Postpartum depression goes on. The feelings of worthlessness or loss in pleasurable activities is severe. Again, with the blues, you may be feeling down and crying and somebody cracks a joke or gives you your foo-foo coffee, and all of a sudden you're laughing and you feel loved and you feel good again. If you're truly depressed, though, you have it's very hard. You may say, I'm going to go for a walk. That always makes me feel better. And nothing makes you feel better. You may think that your life is worthless, but you really haven't made a plan, maybe. It could be you sleep too much or not enough, eat too much or not enough. Sometimes you're functionally impaired. Women can't even go to the house, but there's a severe depressed mood. We educate our families prior to going into delivery about the signs and symptoms. It's particularly important that the support system knows about it so they can recognize and get the patient help, particularly those with a red flag of any history of depression, anxiety, or mood disorders, or if they're having a hard time coping, lack of support, or whatever. We try to get them some help and support prior to postpartum period. And again, that's why we have screening tools. Postpartum depression is more serious than the postpartum blues. It's an intense sadness, and it will persist past the baby's first few weeks of life. The incidence of postpartum depression in teenage mothers is 50% higher than older mothers. A lot of times young teenagers, the life they thought that they would have as a teenager is gone. They've got this baby they thought was a Gerber baby who was going to sleep all night and barely eat and maybe change a diaper or two, and now this baby's colicky or whatever, and is much harder to take care of. So we'll watch out for our teen moms as well for postpartum depression. How do we manage it? If we did nothing at all, most of the time, it'll improve over the 6 months after birth. In fact, a lot of women looking back will recognize they probably were experiencing a little bit of postpartum depression. But some women, truly they need assistance. And when they go to the doctor, sometimes there may need to be a pharmacological intervention. Again, just like diabetes, sometimes you need a little bit of help with pharmacology. But whenever we give somebody a pharmacological intervention, we always need to think of the non-pharmacological options. They need psychotherapy. They need to be in support groups so that they don't feel all alone. We still can use aromatherapy. We can use horse therapy, pet therapy, all kinds of things to help them through this period. So we talked a little bit about postpartum blues, which almost all our women experience some sort of up and downs of the postpartum period due to the fatigue and the hormone changes. But a good portion of those, at least 15%, maybe even more of those women, may go into severe postpartum depression. We know some people have panic disorders as well, and maybe they've had anxiety and panic in the past and thought they were over it. This is the time that it may come back again because they're a very vulnerable period. Again, OCD, sometimes this is the time it appears. Sometimes it's the symptoms get a little bit more severe at this time, so we keep an eye on all those things. Post-traumatic stress syndrome is been followed by many research people, and Dr. Beck is one of those who did a lot of literature and a lot of research on post-traumatic stress disorder among women in the postpartum period. And they found that women whose birth didn't go exactly as planned, maybe they ended up at a C-section and they had trauma with a delivery or whatever, that they may be prone to it as well. We also have to be aware of those people who have had some stress, traumatic stress coming into the pregnancy, such as a result of rape or other stress disorders, violence. And so again, we're alert to what the patient is experiencing during pregnancy, which can cause some traumatic stress for the patient during labor and after. Postpartum psychosis is what you hear on TV when you hear about a mom who, drowned her kids because, she heard God telling her to do that, the hallucinations, or they drove off the bridge. It doesn't happen that often, but it will hit the headlines. About 1 to 2 out of 1,000 births, women will have some kind of a postpartum psychosis. Usually it occurs 1 to 4 weeks after birth, but it can occur up to 90 days. It's characterized by severely impaired ability. They're just not able to cope. They're agitated. They may hallucinate, delusions, somebody telling them to, cause harm to their children, extreme paranoia. It is a severe mood depression, and it is a medical emergency, and it requires help immediately. It's a psychiatric emergency. It is the most severe of mood disorders in the postpartum period. Luckily, there's a good prognosis with early detection and aggressive treatment. So again, it's important to screen our patients and to look out for those who are at higher risk and those who have difficulty coping. So we have screening tools in the prenatal period and in the postpartum period. Before they go home, we need to do a screening tool to see if they're at high risk, to make sure that they get the help and support that they need. Again, management, oftentimes it remains undetected. Again, we have to make women feel safe and know that it's okay to have these feelings, because women are hesitant to report or seek help. So we need to be very compassionate, caring, and make it a safe place for women to feel like they can share what they were feeling. We're looking for signs of depression. Well, we see them, although it's a very short period of time. Their energy level, fatigue, again, the screening tools, again, educating the family and giving them community resources. There's a lot of help out there, and there's a lot of postpartum depression groups that are at the hospitals. Doctors are aware of them, and there's a lot of people who do counseling and psychiatric treatment that specialize in postpartum depression and mood disorders. And that ends the discussion on postpartum depression, a very important topic to be open about and to have women feel comfortable discussing with you about. So thank you.